So as mentioned, I'm going to be talking about evidence-based treatments and evidence-based approaches more generally to borderline personality disorder, but with the consideration of clinical and ethical issues. I'll start and maybe move fast through some of this but I'll start with sort of the general definition of a personality disorder. I imagine that you're a diverse faculty with broad interest and maybe only a subset of you are clinically oriented or even oriented with regard to thinking about personality disorders or personality disorders or borderline personality disorder. But essentially, according to the Diagnostic and Statistical Manual, which is a diagnostic manual that we use in the United States, similar to the ICD-11, a personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of an individual's culture. It's pervasive, tends to be inflexible, and is typically noticeable by adolescence or young adulthood. And it tends to be relatively stable and leads to distress or impairment, mostly within the individual, but some personality disorders actually lead to distress and impairment in others. There are two systems, as I say here, within the DSM for thinking about personality disorders. One is in section 2 of the DSM and is a traditional trait-based or symptom-based approach that has characterized the DSM for about 40 years. And the other is an alternative model, first proposed in 2013 and increasingly being accepted as a preferred model for thinking about personality disorders. In the section 2 personality disorders, there are 10 personality disorders arrayed across 3 clusters. Different versions of the DSM, there might have been additional personality disorders that were considered or even utilized, but in the most recent version, there are these 10 that you see here arrayed across what's called cluster A, cluster B, and cluster C, with cluster B being where we're going to focus, and we're going to focus on this disorder called borderline personality disorder. So borderline personality disorder is actually characterized by a pervasive pattern of instability with regard to one's sense of self or self-image, in interpersonal relationships, and in terms of mood or emotion regulation. And as I said earlier about personality disorders, this begins in adolescence, young adulthood, although often people are reluctant to diagnose the borderline personality disorder or personality disorders in adolescence, in large part because it's hard to sometimes discern whether the behavior of the adolescent is a point in time issue or more characteristic of something that is characteristic of personality. The disorder itself, as I indicated, is stable over time, even though there's these unstable aspects to the way the person functions. And sometimes it's referred to as stable instability or consistent inconsistency. And as I say here, borderline personality disorder is characterized by this consistent sense of lack of consistent sense of oneself, what we refer to as identity disturbance or identity fusion. So the person doesn't have a good sense of themselves over time, they don't have a good sense of what they're invested in and their values, and it flips or vacillates from moment to moment, which can be very confusing to the individual and can also be very confusing to people who are dealing with the individual. And this then manifests itself in chaotic interpersonal relationships, abandonment fears, and attempts to avoid abandonment, emotional instability or lability, poor impulse control, and probably the most perplexing and serious symptoms of borderline personality disorder are the suicidality and self-injurious behaviors or non-suicidal self-injurious behaviors and urges. But these individuals also present with chronic depression, diffuse anxieties, and this can make it difficult sometimes to diagnose the disorder. Now, the name borderline personality disorder may seem counterintuitive. The name sort of calls on one to think about where the borderline is in the conceptualization of the disorder. Initially, it was called borderline personality disorder because the patients with these kinds of difficulties were seen as on the border between neurotically functioning individuals, people with sort of typical sort of depressions or anxieties, and psychotic individuals, people with frank difficulties in reality testing, and so the phrase borderline, or the term borderline, was coined as a way of capturing that borderline. Later in the 1970s, people argued that the borderline was actually with affective disorders, and borderline personality disorders was reconceptualized more as a variant of an affective disorder or mood disorder. I would argue that the issues around identity or self-image, the issues around interpersonal relationships, and the issues around mood are equally problematic, and the borderline is actually the border between those issues, if you think about them as overlapping Venn diagram. And to illustrate this, we did a study where we looked at people with borderline personality disorder as compared to people with anxiety disorders over a 21-day period, where we used smartphones to assess various aspects of the patient's experience and as related to specific events that the person may be experiencing. And so we actually had about, on average, 13 assessments a day over a 21-day period. And so we had, with our 55 patients, about thousands of data points, and we were able to look at the interplay between various aspects of experience and these difficulties that borderline patients present with. So one hypothesis with regard to borderline personality disorders, you see all this suicidality, suicidal urges, suicidal behavior, because the person's mood dysregulated, and the dysregulated mood leads to these kind of behaviors. And we examined that, but we examined that idea in the context of self-concept or as a proxy for identity. So what we did is we looked to see whether negative affect or mood dysregulation predicted self-injurious urges or suicidal urges, which we could find a main effect for. But we found that that effect was moderated by moments of being in identity diffuse states, or moments where self-concept clarity was low. And so the finding essentially is that if you're in a negative mood state, there's a main effect that you might be at risk for self-injurious behaviors, but really only in the context of when one is identity diffuse. And I share this in part to illustrate the interplay between these three areas that I think is actually the new borderline for borderline personality disorder. But the name itself, it's not a evocative name like depression or anxiety. It's more a name like the old dysthymia or schizophrenia, in that the name itself doesn't necessarily evoke to the listener what it might be about without some more knowledge. We've also found that borderline patients have less stable self-representations and more negative self-representations. We found this both in behavioral Q-sort data, but also corresponding to brain imaging and brain regions associated with those areas. And we also actually found that borderline patients have less of an ability to actually evoke a representation of themselves. So this is a procedure called reverse correlation, where you show people two pictures, like in the A frame up top, and the person's supposed to pick the one that looks more like them. and neither of the pictures necessarily look like the person. So, you have to pick, based on some, judgment or intuition of which is more like you. And you get 300 trials of this. And based on the 300 trials, a composite picture is developed. We can then look at the composite picture, which you see in B, to your left-hand side, and compare it to the person's actual picture and see how similar their composite is to their actual picture, with the idea that the capacity to do that indicates one's ability to actually have a clearer representation of one's own actual image. And when we did that, we found that borderline symptoms were actually related to decreases in the similarity between the composite and the person's actual picture. The picture on top to the right is actually the composite. The picture on the bottom is the opposite of the composite. Here in the United States, we think it looks like Babe Ruth or something like that. But you can see the top picture looks relatively similar to the picture of the individual. And I present all this just to show some of the centrality of not just emotion dysregulation in borderline personality disorder, but also the identity concerns. I could do the same thing with regard to the interpersonal concerns. So shifting back and thinking about borderline personality disorder in the DSM in section 2, there's 9 criteria, and the individual has to meet 5 of those 9 criteria. And here you see the various criteria listed. Because there are 9 criteria, this is a polythetic approach where there are about 256 different combinations that one could have for meeting the criteria for borderline personality disorder. It sounds pretty heterogeneous, but we'll talk a little bit about that later. The other way of thinking about borderline personality disorder in the DSM is this alternative model, which is actually called the alternative model for personality disorders, or AMPD. And this is actually based on assessments of what's called the level of impairment in personality functioning and the presence of personality, pathological personality traits. And personality functioning is the degree to which the person has an intact sense of themselves, a clear, coherent picture of themselves or identity, that they can invest in various things that they're interested in, and that they show self-directedness. And the interpersonal domain is about the capacity for healthy empathic relationships and the capacity to have mutually defined, mature interpersonal relationships with others. The pathological personality traits that are noted include negative affectivity, and antagonism, disinhibition, and these, and I'll say more about this, actually align to with the 5-factor model that people may be familiar with of personality in general. And then there are select personality types or styles that one would then choose as characteristic of the personality pathology that the person is experiencing. And here, the range of different types or styles is actually less than what we saw in section 2. It's not that those other disorders are not necessarily thought to exist, but these are the ones where they felt that there was high enough prevalence and empirical support and algorithms that allowed one to make the diagnoses. And so there is also a PD trait specified option that allows you to essentially say, hey, there are PD traits here. They don't necessarily meet criteria for any one of these 6 personality disorders, but here are what the traits are that are actually seem to be prominent. This model, interestingly, is very consistent with a model that was developed by Otto Kernberg and his concept of personality organization. In some ways, they're remarkably similar. So Kernberg had hypothesized that you could diagnose borderline personality disorder as being along an array of or levels of personality organization, he called it, with low levels being at a psychotic level and high levels being at a neurotic level, which you can see to your left here. He also talked about this in terms of severity of the pathology, and that's very much consistent with this alternative model conceptualization. And you can see here that borderline personality disorder is in the low borderline personality organization level. And Kernberg's model has many more different personality styles or personality disorders than the DSM Section 3 or even the DSM Section 2. What's interesting about this is that the alternative model is an empirically derived model for the most part, with some controversy and some emphasis, some emphasizing the negative personality traits and others the levels of personality functioning, which I think is akin to Kernberg's level of personality organization. But Kernberg actually had articulated this back in 1967. Model was, fully articulated by 1975, and it's interesting that the empirical literature then sort of converges with the theoretical hypotheses here. As I said, there's also these pathological personality traits that negative emotionality, detachment, psychoticism, antagonism, disinhibition that correspond loosely to the 5 factors. You may know the 5 factors as, as neurotic, extroversion, openness to experience, agreeableness, and conscientiousness, sometimes also called not the FFM model or the NEO for the 3 top loading factors, neurotic, extroversion, and openness to experience. And interestingly, Kernberg's model actually captures that too. So there's the introversion, extroversion dimension, but it also captures the neurotic dimension in the levels of personality organization, and high levels being more on the neurotic side. As I said, the introversion, extroversion dimension, the openness to experience, the opposite end of that is actually psychoticism, and which you can see at the low end here. And then the agreeableness can be captured by, or dimension, agreeable to antagonism dimension, can be captured by obsessive compulsive to dependent personality disorder. And then the impulsivity or disinhibition or conscientiousness could be seen in the more histrionic, narcissistic dimensions. As that improves, one would be much more conscientious. As that decreases, one would be more impulsive. I just thought that that was a sort of a curious correspondence there. So let me shift gears here now and just quickly talk about the epidemiology and clinical prevalence and characteristics of borderline personality disorder, because I think it's important to know. And I often say that in order to be an empirically supported therapist and treater, one actually needs to understand the empirical evidence around the general psychopathology and the epidemiology. So it turns out that borderline personality disorder is highly prevalent, 1 to 6% in the general population, the median of 2.2%, about 10 to 25% in psychiatric outpatients, about 20 to 25% in inpatients. And one study looking at primary care patients actually found 6% of the people in a waiting room actually met criteria for BPD. And it's important to understand that that prevalence actually makes borderline personality disorder quite prevalent. In fact, it's more prevalent than schizophrenia, bipolar disorder, autism combined. And I say that by taking the highs and lows of the prevalence rates for each disorder. That makes it a pretty important public health concern, at least at the level of prevalence. It's a heterogeneous disorder, as I indicated earlier. That there are 256 different possible variants of Section 2. Section 3 makes it a bit more coherent, but people have suggested, well, given that heterogeneousness, maybe that's actually an argument against the validity of the disorder, but people don't necessarily levy those kinds of critiques against MDD or PTSD, which also are pretty heterogeneous disorders, as you can see here. In DSM-5, there are over 500,000 different combinations for PTSD, and people don't necessarily doubt that it exists. I think that the reality of and complexity of people's experiences, that there are shared components, but there's also heterogeneity. As I alluded to before, too, the most probably significant aspect of borderline personality disorder is this lethality with regard to suicidality. 75% of patients engage in self-injurious behaviors, cutting themselves, burning themselves, doing other things that are potentially self-damaging. Average patient has 3.5 suicide attempts. Suicide rates range from 4 to 10%. And 78% of the suicides in borderline personality disorder occur 5 years after the discharge from a hospital, and most likely occur with patients in their 20s or 30s. So if you're treating a patient who has engaged in self-injurious behaviors, who has been hospitalized and recently discharged, and who's in their 20s and 30s, you have a highly lethal patient. And so the significance is high for this. Meta-analysis of 1,100 patients found an 8% suicide rate, and that compares to other disorders like schizophrenia, depression, anorexia, unmedicated bipolar disorder, PTSD, as very high. And so often when we think about suicidality and risk for suicide, we think about depression, which certainly makes sense at an associative level, but the level of suicidality is actually, and the rate of completed suicide is actually much higher for people with borderline personality disorder. Now, I want to talk a little bit about the comorbidity. And because borderline personality disorder is frequently comorbid with other disorders, sometimes people have said, well, that comorbidity might actually undermine the validity of the disorder because maybe it's these other things. But as I point out here, BPD is commonly comorbid with other disorders, but in a pretty uncommon way. And that is that it's comorbid with both what are called internalizing and externalizing disorders. Internalizing and externalizing disorders are thought to be orthogonal and unrelated, although in borderline personality disorder, you see actually both types of comorbidity, which is an interesting complexity to the disorder. Moreover, the comorbidity with BPD is meaningful. So BPD comorbidity results in poor inter-episode functioning for other disorders, decreased employment, increased medication use, increased alcohol and substance use, and decreased treatment responsivity, as well as increased suicidality. And BPD comorbidity negatively affects the treatment outcome for otherwise efficacious treatments. And so if you have a patient with major depression and you have empirically supported treatments for major depression, manualized treatments that might be typically very useful and effective, if the patient has a comorbid borderline personality disorder, then the efficacy of those treatments are likely to be much less. And so the clinical utility of knowing about the comorbidity of disorder is actually pretty important in that regard. And I cite a host of studies here, but I could have cited a whole slide full of studies. There's that many of them. Interestingly, the relationship between BPD and other disorders tends to be one-sided. And what I mean by that is BPD tends to affect the course of other disorders. Here I give 2 examples, MDD, major depressive disorder, and bipolar disorder. but the comorbidity of those disorders with BPD actually has little effect on the course and outcome for BPD. I'm not saying that those other disorders wouldn't be important if comorbid in a person with BPD, but the evidence suggests that we should be privileging the information about the BPD comorbidity for those other disorders than the other way around. So, so for instance, clinically, if we have a patient with BPD and MDD, we don't want to necessarily privilege the MDD over the BPD because the relationship doesn't seem to work that way. Treating the BPD will help with the MDD remission, but not necessarily the other way around. And the same is true for bipolar disorder. Turns out actually that even people who are below the threshold for borderline personality disorder, 5 criteria on the DSM section 2, even 3 criteria actually predicts membership into the latent class. But even one symptom seems to be problematic. Mark Zimmerman at Brown University found that one BPD symptom actually predicted increases in comorbidity, increases in suicidality, less lower functioning, and disruptive employment history. So, even if somebody doesn't necessarily meet criteria, we should be vigilant. So I think there's several evidence-based implications or principles one can derive out of this. Given the prevalence of BPD, all clinicians need to actually develop specific expertise in at least identifying and diagnosing BPD. So if they can't necessarily treat the patient, they at least need to be able to recognize it and then triage the patient to an appropriate treater. And given the range of comorbidity, the frequency of comorbidity, and the negative course on those things, that whenever there is a comorbidity, it's incumbent upon the clinician to assess for BPD, or stated differently, whenever one assesses a patient as having one of these frequently comorbid disorders, one also needs to assess for BPD. And I would suggest, particularly if there are multiple disorders and in this complex pattern, which I think is suggestive of BPD. And as I said earlier, BPD and these other disorders can co-occur and they can be independent, but often BPD is predicting the course and outcome in these other disorders, and we should not ignore BPD and the idea that treating these other disorders will lead to improvement in BPD, because the studies actually show the opposite. And these are several large-scale studies over long periods of time with, at this point, thousands of patients. So it's pretty convincing. I'm gonna skip this because I think I actually may have said this along the way, and for the sake of time, I'm going to talk a little bit about assessment and diagnosis before I get into talking about treatment implications and the treatment findings. And because what's important here is it turns out clinicians are not good at diagnosing borderline personality disorder. This is a large study done by Mark Zimmerman, where they looked at 500 patients who were seen in the outpatient clinics at Brown University's hospitals. And they found that out of the 500 patients, only 2, less than 0.5%, were given a diagnosis of BPD. At the same time that clinically these patients were being seen, and Zimmerman had research assistants actually assess the patients using structured interviews. And through the structured interviews, they found that almost 15% of the patients actually had BPD. So it means that less than 3% of the cases were actually being identified, or 97% of the cases were being missed. The research assistants then shared the diagnostic information from the structured interviews with the clinicians. And in about 2/3 of the cases, the clinicians actually changed the diagnosis to BPD, so raising the prevalence to about 10%. When I first arrived at Penn State, we weren't doing structured interviews for personality disorders. I implemented that as part of my research program. And the prevalence rate of BPD when I first arrived was actually 4.2%, 1.6 through structured, they weren't doing structured, through the clinical assessment, and 4.2 after supervision. But once we implemented the structured interviews, actually the prevalence rates went up to about what Zimmerman saw. And so it's important to be doing these structured interviews. The literature shows that it takes 6 to 10 years before somebody is diagnosed with BPD from their first psychiatric contact. During that time, they're given a host of other disorders and are essentially misspecified and misdosed in the treatment that they're receiving. So the evidence-based principle here, I would say, is that structured or formal interviews identify many cases that would otherwise be missed in ordinary clinical practice. And I think it's important that one is doing some formal interview, and that the feedback from these kinds of interviews is clinically useful, has clinical utility. And again, the failure to do so leaves patients misspecified and incorrectly treated or dosed. I'm going to say a little bit about longitudinal course, but I think I'm going to go through this material a little bit more quickly than I normally would, just so I have time to get to the treatment data. The long and short of it is that it turns out that borderline personality disorder is fairly stable. There is some evidence that that the diagnosis itself may come and go over time, which is somewhat concerning, but the levels of functioning actually remain about the same. And here I'll show you, this is 10 years of functioning on a basis of a GAF rating, which is a global assessment of functioning score. And you can see at the top line is people with major depression. Underneath that is people with obsessive compulsive disorder, and the borderline patients are in the gray towards the bottom. You can see that their function is pretty stable and low compared to the other two disorders. Additionally, over time, there is remission, but not nearly the same kind of remission that you see in major depressive disorder or even obsessive compulsive disorder. So the long and short of it is there may be symptom reduction over time, particularly with regard to impulsivity, chaotic relationships, but the functioning actually stays pretty poor over time. And I say that, to think about the validity of the disorder. So let's segue into treatment considerations. Historically, borderline personality disorder has been thought to be very difficult to treat. People have written up case reports noting high dropout rates, chaotic use of service, high lethality, and many clinicians are actually intimidated by the prospect of treating patients with borderline personality disorder and pessimistic about the outcome for such patients. And this leads to therapist burnout. And some people have noted that therapists may be prone to what are called enactments of our iatrogenic behaviors in psychotherapy. Therapists, when I talk to them, they worry about being provoked by the patient and acting out, getting angry at the patient. It's been my experience that therapists generally don't get angry at the patient, at least not overtly towards the patient, although they may feel activated on the inside. But the biggest enactment or iatrogenic behavior that I see therapists engaging with patients is passivity, that they get demoralized in the treatment and they just get passive, which of course is very problematic because then the patient is stagnating and the treatment stagnates. It turns out that standard psychoanalysis or psychodynamic psychotherapy and standard cognitive behavioral therapy lack efficacy in treating borderline personality disorder. And there are a number of important modifications that have been made both to cognitive behavioral therapy and psychodynamic therapy, as well as to our thinking about what are called common factors that might cut across the different treatments. And that has led to the development of specialized treatments for BPD, which have shown efficacy. And here underneath this, at the bottom of this slide, I'm showing data from an RCT comparing CBT to treatment as usual, which found no significant differences, and why I would strongly suggest that standard CBT wouldn't necessarily be useful. There aren't necessarily direct comparisons for psychoanalysis or psychodynamic psychotherapy in general, but both Kernberg, who developed a dynamic therapy called transference-focused psychotherapy, which I'll talk about, and Linehan, who developed a what's called a cognitive behavioral variant called dialectical behavior therapy. Both of them actually developed their specialized treatments as modified versions of the of psychodynamic and CBT, respectively, noting that the pathology required modifications of technique. Over time, there have actually been several treatments that have been developed that have now shown efficacy in randomized controlled trials. I array them here as a function of whether they are cognitive behaviorally based, like dialectical behavior therapy at the top, or psychodynamically based, like mentalization-based therapy and transference-focused psychotherapy, or if they're considered sort of a generalist approach. And I can say more about that in a bit. Another way of arraying these treatments is this general approach, like good psychiatric management, specialized treatments, and then adjunctive treatments, treatment modules that you can add on to other treatments to potentially enhance the treatment of the disorder. In a different kind of big five, not big five personality traits, but big five psychotherapies, I think that dialectical behavior therapy, mentalization-based therapy, transference-focused psychotherapy, schema therapy, and good psychiatric management, which is a specific version of psychiatric management articulated by John Gunderson, not simply good psychiatric management, are probably considered the big five of those psychotherapies. Dialectical behavior therapy may be the therapy that's most well known and certainly the most studied, most disseminated, and people may be aware of it. And here I say it's an integrative cognitive behavioral therapy, typically once weekly with weekly group sessions, adjunctive telephone consultations. So it's time intensive, and it focuses on skills training in the context of validation and balancing acceptance and and tolerance of where one's at, but also with the impetus to want to change. And there are efforts to generalize the skills and reduce therapist burnout. And as I say here, there are about 14 RCTs of DBT with BPD. Sounds like word salad when I say RCTs, DBT, and BPD like that. Mentalization-based therapy is a specialized form of psychodynamic psychotherapy, has individual and groups and several phases to the treatment. I won't say much about that here for now. And schema-focused psychotherapy is integrative manual-based, I say cognitive therapy in quotations, because although it derives out of Beck's cognitive therapy approach, it's quite integrative explicitly, drawing on concepts from object relations like Kernberg and attachment theory. And we'll talk more about this treatment in the context of the evidence, but I won't go into too much detail here either. Transference-focused psychotherapy is based on Kernberg's model, which I presented a bit earlier. It's, again, a modified dynamic treatment, involves twice weekly face-to-face sessions, and its efficacy has been demonstrated in several studies, both with regard to symptom change and changes in personality structure. And here I would say transference-focused psychotherapy is probably the most ambitious of the treatments, because in addition to trying to reduce the symptomatology associated with BPD, it really is focused on trying to change the person's personality so that the person's functioning is actually different, not simply from learning skills that one might be able to evoke and use in certain situations, but actually from the inside out, just having psychological structures that actually make it so that the person may function differently. And I won't go into this detail quite at this point. As I said, good psychiatric management is developed by Gunderson based on the APA practice guidelines, although it's evolved over time, and it functions on these areas outlined here. And I guess I would say that the big five, they are different in several ways, but they also actually have a lot of similarities. And I actually made a table that sort of shows a comparison of these various approaches in terms of their emphasis on unstable self, unstable mood, or unstable interpersonal relationships. And you can see here that DBT focuses mostly on the mood aspects, and MBT on the interpersonal relationships, and TFP on the unstable self, and good psychiatric management on interpersonal relationships. But it's really much more of an issue of emphasis than it is exclusivity in one of these areas. All the treatments actually have a focus across these domains. I'm going to say something briefly about medication, and I won't harp on this too long. But simply, and I start with this cartoon of this person. You can't see what it says underneath, but essentially it says, I medicate first and ask questions later, which is consistent with a lot of practice, at least in the United States. Initially, there was an approach to medications with borderline personality disorder, which focused on targeted areas of dysregulation. And you can see here some of the medications that were articulated in that context. Unfortunately, this led to sort of polypharmacotherapy, where patients ended up being on 3, 4, 5, 6 medications, with medications to help with side effects. And that also had some bad consequences. And it's safe to say that there's no one medication indicated for treatment of BPD, although one might argue that using one medication, and I'll say more about that, might be the best way. A number of medications are used for targeting symptoms, but little support for the polypharmacy. The medications are not necessarily going to result in dramatic changes in underlying personality organization. Borderline patients tend to be less responsive to medications, often with paradoxical side effects, and can use the medications for overdosing. There are other iatrogenic effects. Long-term use of these medications, and here I'm talking 5-10 years, leads to obesity, hypertension, diabetes, and metabolic disorders. And the risk of these disorders on medications is greater than if one had a family history of obesity or regularly did not exercise. So it's pretty striking. The general consensus is that these medications are best used adjunctive, and that people should be trying to base medication use on safety and tolerability with regard to presentation. There is some evidence that using one medication as opposed to polypharmacotherapy results in better outcome. So switching to thinking about psychotherapy, what does the evidence suggest regarding the psychotherapy for borderline personality disorder? How does one make sense of all the different treatments that exist and the different randomized controlled trials that exist? And the argument here that I would make is that we want to look at what are called meta-analyses or meta-analytic data. And I'll say just briefly for people who may be familiar with what meta-analysis is, but it's simply a procedure for combining results from many different studies. And so one takes the outcome measures and converts them across the studies into a common metric that allows one to estimate the direction and magnitude of what's called an effect size, which represents the strength of the effect. And you can look at the significance of those effect sizes, and you can look at moderation of those effect sizes, although most studies of moderation don't work very well because of several statistical issues. So what is an effect size? An effect size is essentially determination of either a pre-post or a between groups effect, the differences between either time 1 and time 2 in the pre-post, or differences between one treatment and another treatment. And this is a sort of a classic example that I'm showing here, comparing psychotherapy treated patients to untreated patients. And this is sort of a replica from the Glass and Smith studies that showed that psychotherapy was led to larger effect sizes than for untreated people, such that 76% of untreated people had poorer outcomes than the average person treated in psychotherapy. There are alternative effect sizes, something called the number needed to be treated. I like this one in particular because it's really hard to think about those effect sizes and what those numbers actually translate into but the number needed to treat is actually a way of determining how many patients would you need to treat in your practice before you would see one that actually had improvement compared to the control. And so the ideal number is one, that is everybody improves compared to the control. And the higher the number needed to treat, the less effective the treatment is. And in psychotherapy studies, we tend to find numbers needed to treat, or this NNT, between 2 and 5. A little bit higher with the more difficult to treat disorders, and lower with the more easily treated disorders. Now, there are several critiques of meta-analyses and several recommendations. I won't go into these critiques right now, but if there's time, people have questions, I'm certainly happy to talk about it. And as I said, there are a number of recommendations and guidelines for how one actually reports a meta-analysis. And it turns out there's been several meta-analyses, as I show here, with regard to treatment of borderline personality disorder. The original one was a Cochrane report of 8 studies, essentially said, it looks like psychotherapy for BPD is effective, but given how few studies there are, we can't reliably say that, but probably a good bet that we should be studying this more. Most recently, or I shouldn't say most recently, recently, there was a meta-analysis published in JAMA Psychiatry, this was one of 33 trials of over 2,000 patients. And they found small to moderate effect sizes across outcomes and across types of therapies. There was no differences between the DBT and the psychodynamic therapies. In fact, the effect sizes for the psychodynamic therapies were a bit higher. There were no differences in dropout between DBT and the psychodynamic psychotherapies. And I mentioned that in large part because often people will privilege dialectical behavior therapy, but the evidence, at least from this large scale 33 trial meta-analysis, is that that's not necessarily warranted. There was also a study looking at DBT specifically compared to other treatments, waitlist controls, treatments as usual, and active treatments. And there they found a moderate effect size for DBT, except when you actually looked at DBT compared to active controls, and there was no difference in the effect size. So consistent with the finding I just said, and not surprisingly, because the data is being drawn from the same pool here. Most recently, there was another meta-analysis looking at 20 trials, 1,300 patients, and also essentially came up with the same conclusion. Given that, I'm not sure why my colleagues and I decided to do a comprehensive meta-analysis, but we did. I summarized the results of our meta-analysis in this one slide for the sake of ease. Essentially, we found in the top left-hand corner that there were moderate to large effects for pre-post differences in outcome. And that was very encouraging finding. However, when we looked at the between group differences, which you can see in the bottom left-hand side, there was actually only small effects for between group differences, which was very sobering. We looked at several moderators, and most of them did not come out, but one moderator that did come out was actually the control, the level of control. So you can see that on the right-hand side at the top, that the number needed to be treated overall was 6.7. That was also very sobering, right? You'd have to see almost 7 patients in your practice before one would be doing better than somebody who wasn't practicing this empirically supported treatment. Now, that doesn't sound like a lot or very good, but if you consider how many people actually are suffering from BPD and are out in society being treated, it actually does add up, but still sobering. However, if you compare people in these specialized treatments to people on a wait list, the number needed to treat, the effect size and the number needed to treat gets much better, 3. If you compare those individuals to treatment as usual, it gets large again. And then if you look at different levels of control, like comparison to an alternative empirically supported treatment, or to a component control, the numbers needed to treat get extremely high and the effect sizes get much lower. What this says, I think, is that, essentially, you're getting better than what people would, people are getting better than if they weren't in treatment. They are in some sort of treatment. You're getting some effect that you can see over a large swath of people, but you don't really see necessarily an individual practice that easily. We then looked at theoretical orientation as a predictor, and similar to the other study I reported, we didn't find any differences between psychodynamic and cognitive behavioral therapies, nor differences between DBT and non-DBT therapies. And so, I think the findings across these meta-analysis with different ends in terms of the number of studies and the number of patients. Our study had 73 different studies, so it was the broadest in terms of studies. We looked at all different methodologies, not just randomized controlled trials. But regardless, the findings are pretty consistent across these groups. We also did a second meta-analysis where we looked at therapeutic alliance as a predictor of outcome. And therapeutic alliance is generally considered a pretty robust predictor of outcome. The folklore is across, all different treatments and all different disorders. But we look specifically at the therapeutic alliance as a function of BPD. And although it was only a small number of studies that we were able to include, you can see down at the very bottom, 8 studies, the effect size was actually quite small, and only 1% of the variance was actually predicted by therapeutic alliance. And the reason we think that that's the case is that therapeutic alliance typically measured early in therapy, like the 3rd session. For BPD, we don't think that that's necessarily the predictor of outcome. We actually think that a good alliance is the outcome. And so you see variable alliance in borderline personality disorder, as you might expect, right? I mean, it's not just instability of self-representation and instability of mood, but also instability in interpersonal relationships, including the relationship with the therapist. And so over time, what you see is this instability should probably get more stable, that the band around the instability should get narrower, and then alliance is the outcome per se, not necessarily the predictor. And the reason why I think that finding is important is I think it's naive to sort of think that the way to treat these individuals is simply to have a good relationship with them and have a good alliance. I think it's a much more complex process. So I'll just summarize some of these findings real quickly, and maybe just make the point that we did not find evidence of superiority of any treatment over another treatment, and that all the empirically supported treatments seem to have about the same level of effect, and a level of effect that is better than the non-specified treatments, and certainly better than people not being in treatment. And we think that the reason why that's most likely is that there may be several roads to Rome, but not every road leads to Rome, and that there are these what I would call uncommon common factors. And the reason why I call them uncommon common factors because they're not the same common factors that might exist for the treatment of depression or anxiety, but they are similarities between the various treatments. So all of them have used trained therapists working in specific but integrative models under supervision. They all set frames. They all encourage the therapist to be active and engaged and proactive, and they pay a lot of attention to managing the relationship, not simply developing a quote unquote good alliance, but recognizing that relationship will be variable and that one needs to be responsive to ruptures that may occur and that they're inevitable. We made such an argument in a conceptual paper in 2015. You know, as I said, these treatments tend to be integrative. There are a few differences, a few prescriptive indicators at this point, and I think that's where the research needs to go. What patients do better in DBT versus TFP versus MBT versus schema-focused therapy, if there are predictors of response to those different treatments. And I also think that because of these findings about equivalence, communities should have more than one type of treatment available to patients, and treaters might consider knowing more than one type of treatment, particularly treatments that cut across theoretical orientation. So, you know, knowing DBT and maybe MBT or TFP, or knowing TFP and, you know, maybe schema-focused therapy or DBT, as opposed to DBT and schema-focused therapy or MBT and TFP, which would be sort of within treatment approaches. Okay, this kind of just reiterates what I said. Guess I'm just belaboring that. And here, you know, I think a general consideration is that all clinicians need to develop expertise in identifying, diagnosing BPD. Structured or formal assessments are important, especially when there are disorders that are commonly comorbid with BPD, not the privilege one treatment over the others necessarily, and that clinicians have a range of treatments available to them, and these include DBT, schema-focused therapy, and psychodynamic treatments like MBT and TFP. I do have more material that I was prepared to go into if there was time, but I see that it's a little after 1, and I wanted to leave time for questions and answers. So I am just going to skip through that. This was more specific stuff about TFP. I will stop in 1 second just showing this map of where we have TFP trained therapists, in part because you can see that Poland is well represented in transference-focused psychotherapy. And then I'll just end here and say thank you for the opportunity to speak with you, and I hope the information was useful, and I look forward to further discussion.